conference will now be recorded.
All right. Sometimes she talks fast, sometimes she talks slow.
Oh my gosh.
So good evening. This is the low intermediate prostate cancer group for AnCan on November 24th, 2025. Welcome everybody. We got a nice sized crowd here with 19 people so far. So this is one of many groups that AnCan offers. We have a high-risk group, active surveillance, under 60 prostate cancer men's group, and I think that's redundant, right? So, and a gay and bi men's group. So this group here focuses on trying to determine, possibly determine a treatment path, and we don't really discuss recurrence in this group. So if you're someone who's had recurrence, we urge you to attend our advanced group. You're welcome to stay here, but like I said, we don't really discuss recurrence so much. So we probably won't talk about whatever you need. AnCan thanks the following sponsors for making this recording possible. We are sponsored by Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation, and Foundation Medicine. So the views expressed here are solely the opinion of AnCan Foundation, our moderators, and you guys, the participants. So AnCan moderators and your fellow participants, with a few exceptions, Dr. John, we are not medical personnel. We don't give medical advice. We help you with peer support, and you will see what we have experienced and hear what we've experienced, and hopefully that will help you in your experience. So we don't accept sponsored promotions from those sponsors. Any drugs, protocols, or devices discussed are based solely on anecdotal, experience or clinical evidence that we are aware of. And again, like I said, we don't give medical advice, but anything you do hear here, we will encourage you to discuss it with your medical team. So as always, we start with our new guys, and tonight that is Martin. How did you say your last name? Was it Ute?
Yes, it's Ute.
Ute. Okay. All right. So I think I can guess what brings you to AnCan. So with our new guys, we like to ask some questions, just trying to figure out where you're at in your AnCan. In your prostate cancer journey.
Of course.
And I apologize for my voice. It's been going bad since this morning when I didn't really yell at somebody, but
Oh.
So Martin, how old are you?
I'm 67.
67. All right. And how'd you hear about us?
Well, long story short, I spoke to a surgeon who does cryotherapy, and I had contacted Dr. Olam. He's at Northwestern in Chicago, and so I emailed him saying I'd like to talk to somebody, either in a support group or someone who's done it. And so then his PA sent along information, and so then about the group, and then I think it was Jim, and so Jim contacted me and said, "Here's the link for tonight. They may be helpful." So
here I Jim am. Marshall.
I would know.
Oh, Jim Schrade. Okay. Yep. Yeah. Yep. So was that your doctor? You said Dr. Ulan, I think.
Oh yeah.
Was
so Dr. Ulam, who is the cryovac, or I say cryovac, but yeah, cryotherapy guy. And then there is a radiation oncologist.
Well, let's back up a little bit.
Okay.
So you were diagnosed with prostate cancer before you went to see the radiation guy and the cryotherapy guy, right? So what was your diagnosis? Your Gleason score? Did you have
Gleason
a biopsy?
Score was 4+3.
Okay, so was that you had a biopsy? You had a Gleason score of 4+3. Was that several cores? Do you know how many cores were positive? How many cores were taken?
I don't offhand know.
Okay, what type of biopsy did you have? Was it transrectal or transperineal?
It was transrectal.
And was that guided by an MRI? Was it an MRI fusion biopsy? Did you have an MRI first?
And I had an MRI first, yes.
Okay. And do you know if it was used to guide the biopsy, or was it just kind of like they kind of knew where the areas was and
No, I believe it was
they took a
used to,
stab at it?
no. It was, it was used to guide the biopsy.
All right, good. So right now, you had a 4+3, but you don't know how many cores. So do you have your biopsy report?
I do, but not, well, not handy.
Okay, no, that's fine. So have you sought a second opinion on your biopsy?
Yes, that was why I went to Northwestern.
Okay. And who'd you get
And
the second opinion from?
Well, two people, Dr. Alam, and then there's Dr. John, who's the radiation oncologist.
But you didn't get a second opinion on your prostate biopsy from a pathologist.
No, I'm sorry. No, I did not.
Okay. So you went to consult with a cryotherapy guy and a radiologist.
Right.
So, so not knowing how many cores you had positive and what the other cores were, like you could have had 3+3s or 4+3s or 3+4s in your other cores. I mean, not knowing that, you might be served to get a second opinion. And if do you know where the chat box is in this?
I see a share, but I don't see.
Well, there's a up in the upper right corner. There's looks like a little, like two little speech bubbles next to each other. If you hover over them, they say chat. My fellow moderator Stuart has posted a couple of names, or at least one name up there. A couple names. Let me scroll. Yeah, a couple individuals that will give you second opinions on your biopsy. So, sorry.
In the Chicago area.
No, they are not in the Chicago area, but you can. So what you would do is you would contact these individuals, like Dr. Epstein had out at his website, and you would have your doctor send your slides to them. They would read them again, or Dr. Zhou.
Oh, I see what you mean. Okay.
So, and it may and it's probably covered by your insurance, but if it's not covered by your insurance, it's not terribly expensive. Does anyone know how much they're charging now, or Stuart or Rick?
I think Dr. Zhou is 350 and Epstein is 450.
Okay.
Go ahead. Already, you said it.
If someone could put that information in here, all I see is.
It is pinned at the very top of the chat window. So if you scroll up, you'll see it.
All I see is Boykin. No, I didn't know. No HT.
Keep going all the way up to the top.
That's where I am.
You don't see Dr. Ming Zhao?
You have to click the pin.
Oh, yeah.
A little click the pin
You clicked.
on the same
Hey.
line as the chat, and it's right at the top when you
Yeah.
click the pin.
Gotcha. Okay.
I forgot that if you weren't here when it was posted, you would have to click the pin to see what was pinned in there. So my apologies. So what else have you done in the pursuit of your treatment or your treatment decision, Martin? Have you done any genetic testing?
No, I did have a PET scan,
Okay.
which
What
so
type
there
of
was
PET
no.
scan?
Was it one of those prostate? I mean, specifically the prostate PET scan that was done, and there's no metastatic,
Okay. So do you have copies of all your reports, or are they
I
at your
do.
doctor's
Yeah.
office? So,
Yeah, I have everything. It's just I don't have it handy.
right. So, well, that's fine. I mean, you can always come back and tell us what they say, and we could give you further advice. So what are you looking for? What are you looking for from AnCan?
Well,
Um,
I guess looking at the the cryotherapy versus doing a combination of radiation. And I can't have hormone therapy because I've got cognitive issues, and the radiation oncology guy is worried about that for me if I do hormones.
Right.
But a combination of radiation for 5 weeks, and then after our daughter's wedding in May, I would then have the seeds.
Do
And
you
that's
want
what
to? So I mean, me personally, without knowing a little bit more about your biopsy report, I'd be hesitant to tell you to go either path right now.
okay.
Did you say a 4+3 or a 3+4? I think you
No,
said a
4
4
plus
plus.
3.
You said a 4+3, right?
Yeah.
Yeah.
And why do you say that?
Well, I mean, if you only had one core that was a 4+3, it's mid-level to more of a concern. But if you only had one core and then you had a bunch of other cores that were 6+6 or 3+3 or something along those lines, you might want to look at a different option. So I don't know enough. I don't know enough
Right.
about your biopsy to.
I know. Would you mind if I just went into the room and looked for it, and you guys could talk? Whoever also had time could talk, and then.
Yeah, that's fine.
Okay. I'm gonna mute myself, and then at the end, if we have time, we can come back to me.
All right. All right. I had HT down as new to our group. So HT, what brings you to?
He's not really, but we will.
I know, but
because I think he's been in this group and the AS group, and it's.
what brings you to this group versus versus the active surveillance group?
Hey, Pasta Rick.
Hi, H.
So, hey, John. No, I've never been in this group. And
Oh, really?
yeah, Rick got all excited to see me. I don't know why. I'm really no bargain, and I hope so.
Hey, take what you can get. Rick doesn't like a lot of people, so you know.
I love Rick.
Well, one of the reasons is because after the group on Wednesday, the active surveillance group, and I don't think anybody else here was in the room afterwards, we were talking about you, and everybody
Okay.
said, "What's happened to Howie? Where's he gone? We haven't seen him for so long." And Hugh said, "Oh my gosh, I need to reach out to Howie."
Who said that?
And then Hugh.
Oh,
Hugh
you. Okay. Mm-hmm.
And then what happens 3 days later, or a week later, whatever it is, we see Howie. So we've missed you, Howie. We missed you in Men Speaking Freely. I'll let Dr. John say that. We've missed you in active surveillance. We've missed you.
And we're glad you're still around.
I'm humbled.
I was going to say, look at that face. He's coming up with some very sardonic comment. It is good to see you again. I hope you're well.
Well, here I is, Spanky. I hope I'm well. Yeah, that's always relative, right? So I forget the rules of engagement. Yeah, it's been a while. What do you want to? No, I'm here because I just opened up my envelope with my Decipher results, and if my scores were that high in school, I probably would be doing much better in life. And then on top of that, the Monday Night Football matchup tonight doesn't really excite me that much. So here I am. Yeah, it's Panthers Niners. So.
So what happened with your Decipher score?
87. That but I can So that would be just one question off the bat, how much stock do we put in that? But there's context, everything's contextual with this, right? You have to look at all the other scores and elements. And so my latest biopsy is I got a full house. I got 7s over 6s. So yeah, it's not a bad hand, right? For playing poker. So it's 3 3+4s, and there's another 6 there. Where'd you come from? So when I'm waiting, I talked to Dr. Epstein not long ago. I told him I was going to shoot him over the slides, or have my hospital shoot him over the slides. So as we speak, I'm waiting on a second opinion from him, and I've done that over the years.
Yep.
Most of the therapy I've pursued is when I just get so overwhelmed by this, I just take a nap. That's as far as I've gotten. But
All right.
I was diagnosed in 2021. But I'm the type of guy right now. I have my original tires on my car. They have 80,000 miles on them, and every time I bring my car to the dealer for the last 30,000 miles, they say, you really need to get new tires. And they're barely bald, so I'm guess put stuff off by nature. And and just like when I started on this journey, when the first time I went into the doctor, I didn't even know. I said, all right, what's a prostate? Where is it? What's it do? Why is this a problem? I knew nothing. And thanks in large measure to Rick and his crew and Becky Walensky and all those other guys, I've learned a lot through active surveillance. And because I know I'm teetering here on, I probably need to do some business or get off the pot, right? So my doctor's been urging me to take some action for the last 3 cycles of biopsies. And then tell him, I'll get back to you on that. What else? Fire away. What am I?
So you haven't done anything along any treatment line? Nothing yet? So active surveillance, right?
Active surveillance, yeah, and I've been hanging tough with the 3+4s. Epstein's downgraded me a couple times. At one point, I can't even remember the name of the other place. I'm a little rusty on this. Like I said, had me at a 4+3, then he downgraded me to 3+4. So, but between this Decipher score and the favorable intermediate, I literally I opened up the envelope. I'm like, shit, why don't I go get on one of these calls tonight? Yeah.
Oh, it's John. Somebody is encouraging you to go on active treatment now. However, you're a 3+4 with no metastasis, right? And no high-risk features except for the Decipher score. So the Decipher score predicts that you have a pretty good chance of developing metastatic disease in the next 5 years. So the question boils down to, is that one test sufficient to transition you from AS to active treatment, given that you're a 3+4? I'd like to, hear what my colleagues have to say, but my initial answer is no. I don't know.
Have a good night, guys. Thank you. That's all I need to hear.
I really don't know. It's not in the guide. I don't know of a study or a guideline that says that in itself leads you to active treatment. It certainly leads you to very, very close monitoring, either by PSAs or even imaging. But I don't think active treatment. Can I get some opinions from the other moderators on that?
Well, Howie, can I just ask a question?
Just 1 second, Stuart. How many cores in the most recent biopsy, Howie?
Yeah, I was kind of being literal with that poker hand, but it was 3 3+4s and 3 3+3s.
Six total. And
She
how
said
many?
6.
And how many cores did they take altogether?
13.
Okay, and that was a transperineal.
Yeah, because that's what you guys told me to do.
Good. And
I didn't know that.
who's your lead guy right now? Where's your where did you have this done? Are you still at Einstein?
Maimonides, Dr. David Silver, not the one
Okay.
from Beverly Hills 90210, the actual
No.
doctor.
Okay. 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 Go ahead, Stuart, and then I'll come back with what I think. Go ahead.
Oh, my PSA. Can I just throw in one more question?
PSA.
What's it called when you got the enlarged and you got to pee a lot? The
BPH.
right? Yeah. So I have that. So my PSA is at like 9.8 now, and it had been like in the 6s. So, but I also BPH. Doesn't BPH potentially cause your PSA to elevate?
BPH will cause your PSA to be high also. There's guys that have high PSA and only have BPH. They don't have prostate cancer.
Yeah, and my doctor.
So that's kind of a balancing act, right? If you've got if you've got BPH based on your doctor's diagnosis, but you also have prostate cancer based on your biopsy, then you know your PSA score is kind of a toss up in my opinion, right? And nine's not terribly high for someone who's got a 3+4 and 3+3 biopsy. So
I guess right from Jump Street here, that those two words, toss up, has been. I feel like I've been in the gray areas like almost since day one. I'm 64, right? So if I was 44, boy, I'm kind of young. We should take care of this thing. If I was 84, then maybe taking a nap serves just fine. So 64 and 3+4, 4+3. And I constantly getting like conflicting opinions and it's always been so fuzzy. And when I'm asked, what do you want to do? I always say the same thing. Look, I got a marketing degree from the University of South Florida with a 2.1 GPA. How the hell am I supposed to know what to do? Like, you guys have been, my doctor said, Doc, you've been doing this for 30 years.
My daughter goes to USF
video games
right
and
now.
watching sports. Like, I don't know.
Tell us
Stuart.
tell us about the opinions in favor of treatment now, who they were and what their arguments were, if you please.
Well, my doctor, I like this guy. I feel comfortable with this guy. I switched around a few times because I didn't feel comfortable with some of the guys that, as my dad would say, they had a scalpel in one hand and an invoice in the other, and they had student loans to pay, and it just felt like they were so aggressive. And been through all that stuff. And the first guy I went to did a transrectal, which was not advised and all that. So my current doctor, and I have my next consultation with him in a few weeks, based on this. So yes, he's been urging me to get treatment for the last, I had biopsy in 22, 23, and now 25. And so he's been telling me that he's not comfortable with active surveillance. But then the last two times I went back and I said, well, let's get a second opinion. And Epstein, like I said, lowered my scores. And then I would ask him, well, what if this guy's right or what if this guy's right? Well, and he would say something, well, if this guy's right, that's good news. But if that guy's right, that's bad news. Okay.
So you're still in the same place. Stuart, you wanted to say something, and
Yeah,
Well,
I'm
Jim's got
in,
his
I'm in
hand
a
up.
state of suspended animation. Yes. Yes. for
I
sure.
was just curious, I assume if you've had multiple biopsies or you've had multiple MRIs, have they
Yes.
been consistent, or has there been any indication that there's more activity now than there was in 22?
More activity based on the MRI or?
Yeah.
Like I said, I'm a little rusty, and even because I haven't MRI is always a four, right? What do they call that score? The
Well, yeah, but
The IRADS.
I read
IRADS is
four,
always
but
a 4, right?
the question would be, how much are they seeing on the MRI? And are they seeing more now than they were 2 or 3 years ago?
Okay, yeah. I think the language I think the MRI diagnosed a BPH, if that makes sense. But other than that, nominal. I don't know the exact verbiage they use. I can probably pull out. I have all my stuff here, but I don't think it's been significant
So,
growth
yeah, in layman's terms,
in any tumors.
in layman's terms, you ask your doctor, are my MRIs showing worse as we progress? If you've had the same doctor with your records the whole time, or if you have all your MRIs, if
If
your
the
MRIs
MRI,
are the same across the board,
Yeah, they're
this whole time.
pretty. It's been just a slight. I'm as we're talking, I'm digging through. I have yeah, I don't think there's been any significant growth in the MRIs. Oh, so slight, if any.
Okay.
Yeah, the
James Marshall.
Decipher freaked me out. And last week when I guess the doctor's assistant, or he has like a nurse practitioner, I'm like walking into an appointment at work, and she says, I just pick up the phone. Howard, your Decipher's an 87. Doctor wants you to get treatment. I'm like, all right.
Yeah, I've ran into what do they call them when they're studying to finish up residence? Yeah, I've had those kind of situations. Jim, you had something for Howie.
Two things. Okay, are you on drugs for the BPH? Any drugs?
They prescribed them, but they're in my medicine cabinet, haven't been opened. So no, I haven't taken them. No.
Oh, you have. Okay. Number two, where are these lesions at? Okay, are they in the apex? Are they in the peripheral zone? Are they in the base?
All on the left. I see left medial apex 3+4, left medial mid 3+4, left lateral mid 3+4, left lateral mid 6, left lateral base 6. Yeah.
Oh, base. Well, okay.
Base and mid.
Interesting.
So nothing on the right. And I'm not talking about my political leanings either. I'm just.
Rick, you had your hand up?
I do. So the base is not so bad, but the base is 3+3 from what you just told us. So that's less of a concern.
Yeah, I have a left lateral base. Oh yeah, you're right. Sorry. Yep.
So, Howie, I think you know what I'm going to say to you, which is, if it were me, I'd get my ass over to Memorial Sloan Kettering and get a second opinion from either Dr. Laudon or Dr. Easton. And I would go with what they say.
Let me get this. Yeah.
We've been pushing Easton and Laudon on you for a long time.
Really?
Yes.
Easton?
Yes. James Easton and Vince Laudon. And they're the two best doctors. But there's also a couple of good doctors which Stuart can mention at Weill Cornell. and Sherelle went there. But the reason we like both Laudon and Eastham is because we know that if there's a chance for you to do active surveillance, they will do it. I'm honestly not so sure about who's your boy, Sherelle and Stuart at Weill Cornell,
Jim Hugh.
And anybody
Jim
in New
Hugh.
Jersey?
Jim Hugh.
I thought I saw a New Jersey guy or two on here because that's where I'm at. I'm in New Jersey.
Well, yeah, but the problem is that the Jersey guys don't have the best doctors, and I don't want you making decisions based on where you're located. And right now, you're willing to schlep to Maimonides.
That's why I went there. Yeah, yeah.
Right. So, but Maimonides is not Jersey. So, if you're going to go to Maimonides, screw it. Just go to East. If you can get them covered, that they are really good docs. As is
Eastham, E-A-S-T-O-M or Eastham?
E-A-S-T-H-A-M. Eastham.
T-H-A-M.
James Eastham, and he knows us. He knows Howard. He knows AnCan, and so does Laudo.
That sounds like one of the soccer teams that you'd root against because you like.
Hey, did you see the result last night? Did you see yesterday's result?
More people are waiting to speak. Stop.
No soccer talking.
Okay, I'm getting my hands spanked. Okay,
we'll go off on a tangent.
Yes, but check the result after, Howie. Howie, honestly, these guys are really amongst the top surgeons. Others are too. I mean, Stuart's been treated at Weill Cornell and at MSKCC. Sherelle treated at Weill Cornell. But I really feel that with a situation like this, where just the way that Dr. John summarized it, that you need somebody with that type of experience, because neither Eastham nor Laudon is going to say, let's cut if they don't want to. And you're going to tell them, I don't want to get cut. You're not going to have a problem telling them of that, and they will hear you.
Yeah, I don't have time for this shit. Yeah, no, you guys nailed it. Thank you. Yeah, it's Dr. John, kind of, you put me at ease. I'm glad I came. I end up feeling sheepish when the more time you guys end up taking with me. But your take on the Decipher and Rick, for sure. Yeah, that's just where my head is at as well. I want to, get another opinion, on the big picture beyond Epstein.
Any of you guys who have been treated, and we've got a bunch, John S. and any of you guys who have been treated in New York. And it may not be surgery either. It could be something else. But any of you have any other names that you would suggest to Howie that you can rely on, who you feel would not push him into treatment?
Well, my guy, Timothy McClure, MCCLURE at Weill Cornell, manages a whole AS cohort, as well as he treats. And he was of the doctors I talked to, he was probably the most encouraging if I wanted to do AS of all the doctors I talked to. I ended up choosing to treat, partially, by the way, because of the Decipher score.
McClure's at Weill Cornell. The other two guys, Eastham, was at MSK.
Yeah, I'll put them in, and other guys can put in. Whoops, that was supposed to go to everybody. I'll put these names in the chat window for you, Howie.
All right.
And other guys may put more information in for you.
All right.
Can I ask one general question about insurance? Can I ask one last? I'm going to turn 65 in a few months, Medicare, right? Does that open up my ability to pursue more options? Right now I'm on Medicaid and Medicare. Does that give me, and again, being in Jersey, that's why I kind of can be stuck here for now, but being on Medicare, will that allow me, will that give me more options maybe to be able to go to one of
Well,
these?
it will depend on what you choose, what program you choose.
Okay.
You will have an option in that Medicare to choose a program that will cover you completely at any hospital you want. It will be a reasonable copay, but I can't tell you what it will be. It might be, I don't know, probably anybody here who lives in Jersey on a Plan G and can give us an idea as to what a Plan G costs. My guess is probably around $400 a month. But yes, that will get you to any hospital. Then you've got to look at, if you go into some of the other Medicare plans, you're going to be more limited. But if you know where you want to get treated, you can find the best. But that whole Medicare discussion is another one. You'll come back here, we'll help you more.
I know it's a bigger discussion, but it's the timing that, that's also been kind of in the back of my mind. Yeah. And the Beatles didn't make a song about that one.
Yeah. I was listening to the Beatles today on my walk. Hey, David in Portland, you kept putting your hand up and taking it down. Did you have something to add? Or?
If we're going to wait on the Medicare discussion, I'll reserve my comments.
All right.
Until then.
That's so Howie, we're gonna move on to a couple other guys. You've got a lot to think about. So
your advice to me is to drink heavily.
That's my advice. That's not the group's advice, but I think you should take Rick's advice and go see one of those two docs at MSK. You'll be very well served. So
thank you kindly. Thanks for all the time.
Oh, you're welcome.
Okay, don't be a stranger, Howie.
All right, next on my list is John S. in New York. John, you said you wanted some time. I did mute you, John, because you had a lot of background noise. So
yeah, no, I just wanted to update my 1 year out MSK Gleason 7. Seen Dr. Nagar. Started my radiation, MRI-guided radiation on the Unity Electra at MSK about a year ago. I went from about PSA of 3.2 to 1.2. There's 3 months intervals. So 3.2, 1.2, 0.68, 0.62, and wow, last week 0.34. So I'm heading downward, treading downward. So
you had radiation.
Yeah,
you had radiation treatment, and now your PSA is rising again.
No.
Oh, it's going down.
I said I started at 3.2.
Oh, I thought okay.
And
I heard 2.3
month intervals. Then I went down to 1.2, 0.68, 0.62, and last week, a year out, is 0.34. So I'm treading perfectly downwards. Where my nadar is going to be, I guess we'll find out in 6 to 8 months. So, yeah, basically no side effects. Everything's. What happened to Mark anyway? Dr. Mark.
Well, I mean,
yeah, so he.
That all sounds very positive, definitely.
Yeah, Dr. Nagar at Sloan Kettering. So I got my transperineal with Dr. Who across the street at Weill Cornell. So I just wanted to update that because you guys have been really helpful for me. No fiducials, no spacer, empty rectum, empty bowels. Yeah, everybody said you need a full bladder, not with the Unity Electra. So just throwing my 2 cents, and that's where I'm at. So everything is treading perfectly down, and hopefully I don't have any bumps in the road. So that's all I got to say.
All right. Yeah, we hope you hit no speed bumps also. So.
Yep.
All right. Oh, I thought someone was asking a question, but that's background noise from you again, John.
Might be, yeah. Hold on. I'm sorry.
All right, Tom. Next on my list was Tom O from New Jersey. Tom, you said you wanted some time.
Hi, good evening, everybody. So it's my second visit to your group, and first one was very helpful. Still, I have got just to give you a catch up. I am unfavorable, and I'll give you a quick snapshot because I wrote it down. It makes it easier for me when I write shit down. I had 13 samples, 3 3+4s, 2 4+3s. And recently I've sat with MSK and Robert Wood Johnson. I'm waiting to hear back from Robert Wood Johnson on my PET, what he thinks of the PET scan, which was done a couple weeks ago. Right, it was done the day of our first meeting, or my first meeting with you guys, I should say. I'm curious though, John from New York. How you did strictly radiation? Is that what you said?
Oh, yeah, correct. I'm sorry, what's your name?
Tom.
Yeah, Tom. Yeah, I did MRI-guided cyberknife.
We are allowed to side. We are allowed to side talk, right, gentlemen?
Oh, sure.
Sure. Okay. You can do it in the chat window.
Okay. No. I just and how
do it here too, by all means.
How high were your scores, John?
I think I had 5 out of 12 cores were positive. I had a 4.3, a 3.4, and 3 3.6s. Initially, I had an unfavorable 4.3, but at Sloan they downgraded it to 3.4, and my Decipher came in at, that was the deciding fact, at 0.26. So Dr. Nagar said no ADT. So yeah, I'm very happy. Yeah. So
okay, thank you. Yeah, so I'm actually my Decipher is actually scheduled for tomorrow. I'm going in for that through MSK. I have yet to listen to Dr. Rick and get to Epstein and get him to look at my biopsies, but that is in the near future. Also, currently, basically in the waiting game, trying to figure out the best care team and the best care action to move forward with, whether it's radiation or the surgery. It's all a mystery to me yet. I do like the fact that there's the James Eastham over at MSK. That's not the doctor I spoke with, but I might ask Dr. Gaffney about him and see what he says about him. Because I'm currently with Dr. Gaffney over at MSK. But I'm with Dr. Yang over at Robert Wood Johnson. Does anyone have any experience with Robert Wood Johnson, or comments or thoughts?
Let me just say that where is Gaffney? Is he in MSKCC in Jersey, or is he in the city?
He's in Basking Ridge. Surgery's in the city.
Yeah. It's very hard to switch. Our experience has been that if you've got a urologist and he's assigned to you, whether he's in Jersey or whether he's in White Plains or wherever it is very, very hard to switch docs. It's not impossible. We've seen it. We've done it. But it's difficult, Tom. They don't.
No, I haven't even chosen MSK yet, but they're in the running. Obviously.
Right, but you have a doctor at MSK that you've spoken to, right?
Yes. Yeah.
It's very difficult. It's going to be very difficult to switch to either Loudon or to Eastham once you've got that doctor. And
yeah, that makes sense.
If you want to see a doc in the city, then McClure or Hugh over at Weill Cornell, and we can come up with other names. We can look and see who else we know. But we talk about these docs, but if you've already seen somebody in their institution, it can be very difficult to switch because the institutions don't like to do that.
Yeah, no, that makes sense. I had a similar experience with my orthopedic doctors. I tend to get banged up a little bit in my career.
Are you an MAA fighter?
No, I'm in construction.
Okay.
I played a lot of ice hockey. So I've had a few orthopedic. The other thing that my wife actually stumbled upon a group out of Princeton. I'm trying to look for the email right now. I don't know where it went. Hold on, let me type that in.
Well, again, if you're going to go down south, we would say stick with a center of excellence. And Princeton doesn't have a group that's part of a center of excellence. I mean, Fox Chase could be a very good choice, depending on where you are in Jersey. Dr. Correa is terrific, and everybody we send to him likes him. There are a couple of other docs we know at Fox Chase. We could find you docs at UPenn. But our preference is always a doctor from a center of excellence.
So is the center of excellence a accredited thing? I'm not familiar with that.
The center of excellence is most in the context of cancer. It is a hospital that is either a member of the National Cancer Institute or has accreditation from National Cancer Institute or from the NCCN, which is the National Comprehensive Cancer Network.
Okay.
So when we say center of excellence, we usually mean, and they are invariably teaching hospitals. They are not. They're not a commercial practice.
I assume MSK and RWJ are in there. Are they?
Yeah.
Okay.
Yeah.
All right. Okay. Well, that's my update. I will have more after the holidays because I'm going to get my Decipher score, and I'm going to have another sit down with Dr. Yang down at Robert Wood Johnson next week, because he's in surgery this week and then off for the holiday. But I'll have more on the next go around, gentlemen. I appreciate the time.
All right. Come back and tell us what happens.
I will.
All
And
right.
get those slides off to Dr. Epstein or Dr. Zhou for a second opinion. It's important.
See, Rick said it again.
He's going to drive that hammer home.
We'll send you some emails offline telling you to do it again, too.
He did that. Thanks again.
All right. So
Mark Erickson has put a message in the chat, Bill.
I see that.
Want me to get it, or-
So, John, do you want to? Well, go ahead and address it, Dr. John.
Yeah, I'll get it if you want. You just look up
Yeah,
NCI or NCCN out, and I'll put it in there.
Okay, thanks.
Yeah, John's going to put a link in there to tell you how to find the Center of Excellence. All right, Greg Burns, you were next on my. I'm sorry.
CHS has his
CHS had his hand up. What's up, sir?
Yes, and he had it up before and he took it down. So
I noticed that.
We'll come to you.
CHS, what's up? We don't hear you. Now it says you're muted. It said you weren't muted before, but we could not hear you.
No, we can't hear you. Make sure that, I mean, it looks like you're calling from your phone. Make sure that if you can see the cogwheel at the top, make sure that is your phone is selected. Another thing, at the top on the right, at least on the laptops, there's a cogwheel and you select your microphone. So make sure that the right microphone. Maybe you have earphones or earbuds, yeah, that can screw things up as well. Those microphones and stuff. I don't know. Here's what we're gonna do. You can always call in. You can always call in, and we'll put a telephone number right now. We'll pin it, and you can call the telephone number and ask them why the heck we can't hear you.
All right. While we're waiting for CHS to figure out his microphone problem, we'll go to Greg. Greg, you said you had some time tonight.
Yeah, thanks, guys. It's good to be back. Hey, Rick. It's been a while. I've been offline for a while, and just wanted to give an update and throw a monkey wrench into the mix. Yeah, briefly, I've got some not too different than Howie. I've got some a mixture of 3+3 and 3+4. Had kind of decided to go with treatment of MRI-guided treatment out of Stanford in the new year. I'd also been seen briefly by Mac Roach. So I was kind of between Mac Roach and Dr. Boyansky at Stanford, which is closer to my home. So I kind of lean towards the MRI-guided treatment as opposed to Mac Roach, which is the more traditional SBRT. So that was kind of a decision I'd come to. And then, of course, being a Libra, you kind of start weighing everything and saying, well, but what if? And then I started to wonder about, well, should I consider having it have removal instead? So we just know exactly what we have instead of, doing SBRT. So just getting whiffy-woffy as things get closer. I guess I'm also, getting cold feet a bit. But as it stands right now, I'm scheduled to start the process of the MRI guided in the beginning of January.
And so I don't know your background, Greg.
Yeah,
how many?
shoot. Yeah, 7.
So
PSA started. I was diagnosed in 2023 with a 5.1. It's gone on back and it's been around 5s and 6s until more recently it got up to 7.1 PSA. I've got 3 cores of 3+4 and 3 or 4 cores of 3+3. And it's the 3+4s are most are less than 5%. Yeah, one of them says is less than 10%. I've had second opinions on those, and also second opinion on my MRI, because as Rick knows, my lesion is very close to the edge, and that's why I'm moving towards treatment instead of staying on active surveillance, even though I have a Decipher of 0.21.
Okay. So everybody seems to be in the same area tonight, right? So a couple of 3+4s, a couple of 3+3s, a couple of 4+3s. So
yeah, no 4+3 as far as I know, but and then there's another thing to really add complications. So I've got a neck issue, some tingling and numbness in my right arm, and I use my arms to get around, so I can't afford to lose any more function in my arm. So I've got the possibility that I might need neck surgery. So when do you do that? You do that before? Do I go ahead do my prostate first and then do the neck, or is it urgent that I need to do the neck first and then postpone the prostate? So that's the most recent monkey wrench in the works that's got me confused and also anxious.
yeah, the fact that it's on the edge would be, a little bit of more of concern. So
yeah.
Weren't you going to get a Prostox test, Greg?
Thank you for reminding me. I did, and that came out as a 0.21 as well. Which, from what I understand from Dr. Roach, that's fairly positive.
So most of your indications are positive, but your lesion is very close to the edge of the prostate, so you're worried about it going further, right? So
Yeah, exactly. I had a PET scan in June, and that or July, and it showed no spread to the lymph nodes. But
You know, I guess, Greg, at this point, and you've weighed this up for so long, that if you've
yeah,
come to the decision that the treatment in the tunnel, in the MRI assisted SBRT, is right for you, I wouldn't second guess yourself.
yeah.
You've just got to stick with it. I mean, do I think surgery would be better for you? Probably not. And with significant comorbidities, and the fact that the surgery is going to be much harder on your abdomen than is the radiation, I wouldn't even think about it. I wouldn't even think about it.
Okay.
And in terms of which radiation, you've made that decision, and we would respect it. We're not going to talk you out of it. I mean, the Meridian, is it Meridian? I forget which one it is.
Yeah, Meridian.
Yeah. It's good treatment. And if the guy's good and he's done enough of them and he knows what he's doing, I'd say go with it.
Yeah.
Because you're going to keep flip-flopping and make yourself crazy over this. Ask Howie.
Yeah.
I think I'll have to connect you with Howie offline. And he can make you a little sugar, just a little.
What if your baseline is crazy?
When you say your baseline, you mean your PSA baseline, Howie, or what baseline?
I think he's talking mental baseline.
Oh, your mental baseline. Yeah. Yeah. Well, the two of you, misery loves company. The two of you will love each other. You are brothers. You are. Hey, listen. Maybe you get Howie to meet you out for one of your sessions when you're teaching people out in Bali or somewhere. Howie will come out to that. But seriously,
Shirts are required for that meeting.
Yeah, I mean, it's tough, and we get it. We do get it. I mean, we joke around, but we get it. It's tough to make a decision. But over the years, I think I've come to the conclusion that if somebody has thought about something real hard and finally decided this is what I'm going to do, you don't want to have buyer's remorse at that point. It's taken you a long time to decide. And if you've decided you're going to take the plunge and this is what you're going to do it with, I would trust your decision, Greg. I don't know. What do other people have to say about having made a decision? Those of you who have been treated in this room, and did you have buyer's remorse? Stuart, you just put your microphone on. I was hoping, because I didn't want to pick on you. Go ahead.
Well, one of the doctors who I talked to last year, his comment was, take your time to make your decision, but when you've made your decision, just go ahead and do it and get it done with. And Greg, if you've got neck problems, the MRI Linac is going to give you the fewest, is going to give you fewer treatments than anything else.
Yeah.
And either 4 or 5, and you're done.
Yeah.
So that sounds, from that perspective, it sounds like a good thing. And I had the MRI Linac, and it was, it's reasonably easy treatment. You go in, you lie down, an hour later you go home.
So it is a full hour in the tube. Is that right?
It varies depending on it will vary slightly depending on how many treatments you're going to have.
Yeah. He's saying other.
I'm sorry, I lost the end of that.
He's saying 5.
5.
Thursday, Tuesday, Thursday, Tuesday, Thursday, Tuesday.
Yeah. Your time in the tube will probably be slightly less than. because I had fewer treatments, which meant they doubled up.
I see. Okay. Well, yeah, I heard you earlier, and I was very happy to hear your happy ending. So, and I mean that in all the best ways. Happy ending are good. So,
All right. Anybody else got anything for Greg? I know CHS, you've had your hand up for a while. Cannot hear you. Nope, nothing. All right, we'll move on to John and let CHS try to figure out what's going on. John, your
What
hand's
if,
up.
yeah, what if somebody has perineural invasion? Does that mean that SBRT is still going to be effective, or does that mean that SBRT is going to miss some travel of cancer cells along the nerves and you really need EBRT? Does anybody know?
Yeah,
Because Greg does have that.
yeah, I don't think it makes a difference.
Okay.
I don't think, from what I recall and what I've read, that perineural invasion makes a difference in selecting your treatment choice, John, from what I know.
Because it's still within the prostate, right?
Mm-hmm.
Yeah, Dr. Nagar told me, don't even think about it. I had the same thing.
Yeah. Thanks, John S.
thank you for bringing that up. You have a better memory than I do. Yeah, but I'm assuming that my doctor knows that, or both of them know that. I would assume that if that was an issue, they would have brought it up, but I didn't hear anything about it. But thank you for reminding.
John S., was that what you wanted to comment about, or did you have something
No,
else?
I just want to let you know I was all set on MRI guided, and then I started thinking of seeds. I was racking my brains. I like to, excuse me, mind fuck myself. And then Dr. Nagar says, look, they're all effective, the seeds. I can send you downstairs, but you all set on MRI guided. You should stick with that, but that's your decision. He says, but the seeds could be just as effective. So I'm glad I stuck with my initial inclination to go with MRI guided. And being in the tube, if you don't move, if you properly if it doesn't move out of the target doesn't move, the prostate doesn't move out, you're out of the tube in 20 minutes, a half an hour. My treatments were quick.
Okay.
So it's a non-event.
Yeah. Okay. Did you take the tranquilizer, not the tranquilizer, but the horse pills to calm you down?
I don't think so. I might have had some Clonopin. I might have taken.
I take them when I do an MRI. So
No,
I'll do
MRI
that.
doesn't bother me. Doesn't.
Okay.
But Greg, someone else said this in the chat, but to me privately, I don't know if he wants to speak up, but he said, we recognize that any treatment has consequences, right? Or there'll be some sort of side effect for anything we choose to do, and
yeah,
what you do, you decide what you can live with, or what you want to live with, also.
right.
I had a more advanced prostate cancer. I had several treatments, and I chose the prostatectomy in the beginning. So,
okay.
would I say that I had buyer's remorse? And I had a pretty good outcome in the end, but it took a couple of years. So, probably in those 2 years of struggle, I had some buyer's remorse. But once everything was said and done, no, because I look back at it now and I think I have absolutely zero idea what would have happened if I chose a different treatment.
Yeah.
So, and I'm where I'm at today, and I'm doing okay.
All right.
Yeah.
Well, thank you all, guys.
All right. We are burning through these through everybody that wanted time. We had Mark Mizrek. Am I saying your name right, Mark?
That's actually Mazurek, but
Mazurek, like
yeah.
Missouri?
Like Missouri with a K. Yep.
All right, you're next. You wanted some time.
Yep. You want to ask me those questions in the background, or do you want me to just start?
Oh, are you new?
Yes.
I did not write down that you were new. I'm sorry. My apologies. If I knew you were new, I would have come to you a long time ago.
Mark,
that's
weren't you in the group in this low intermediate group last month?
No, when I clicked on the link that I had received, it took me to the high risk one, if you recall, Rick, and
Oh, you were in the high risk one. You showed
by
up
accident
in,
there. So I just kind of
Oh.
listened. But this one is more valuable because we got to follow up with Howie and find out what kind of tires he has.
He has ball tires.
I mean, I have just the opposite. Every time I put new tires on one of our cars, like after 20,000 miles, they're shot, you know, and it's like the warranties aren't worth anything. So
Yeah, because that's because you live in Los Angeles and he lives in Hackensack. You know, that's the difference. That's what happens.
all that ice and snow and salt on the roads that we have out here ruins the tires, right?
Well, Mark, I do apologize. I did not catch when you said you were new to the group. So we should have got you up front like we did with Martin. So yeah, if you want to give us a rundown, like your age, we don't need to know how you
64.
heard about AnCan since you're here. So all right.
64. Heard of AnCan through the PCRI over the years. Was a participant in a bunch of the active surveillance ones for a while. Last May, at the end of May, my MRI showed a change for the first time in 7 years. The suspicious lesion grew from 1.4 to 1.8 centimeters on its long side, and there was some concern about it being close to the edge of the gland, so it was upgraded to a PIRADS 5. And that led me to get a transperineal biopsy at UCLA with Dr. Brisbane in early September. He did a micro ultrasound guided one where he only took 5 cores, and they were all associated with the actual suspicious lesion. UCLA's pathologist rated 3 of them 3+4 and 2 of them 4+3. All of which had a fairly significant amount of the 4s as a percentage. Subsequent second pathology with Dr. Epstein reduced the scores of the 4 3s to 3-4 and reduced the percentage of G4s on all 5. However, in consultation with Dr. Epstein, he said it's still 40-50%, and so on borderline. He did not recommend active surveillance to remain on it. He recommended some form of treatment. Dr. Mark Scholes, who Rick knows I've seen for 7 years out here, he suggested that I see Dr. Albert Chang over at UCLA for the HDR brachytherapy, the high dose rate. And I actually just spoke with Dr. Scholes again a couple hours ago. We have follow-up appointments to go over some of the tests that I got back. And he feels fairly certain that it's the right thing for me because of Chang's expertise. He told me that he has sent over 500 patients to him, 200 of which had just the focal treatment and 300 of which had the whole gland treated. And he was very confident that it was the right approach for me. But I thought I would share that with the group and see if anyone else has either had or been advised to consider that type of treatment and what their decision-making process was, because Dr. Chang recommends 2 treatments as the standard of care, the protocol. He also recommends treating the lesion, the tumor now, with a higher dose, and then the rest of the gland almost prophylactically. And I'm not so sure that I agree. Dr. Scholes also didn't necessarily agree because he said it increases the chance of erectile dysfunction or impotence when you treat the whole gland. So at this stage of the game, I am leaning towards just doing one, treatment, and only with it being focal, focused on the tumor itself. Ambry test for genetics came back completely negative. No presence of any mutations, BRCA1 or BRCA2. Decipher came back 0.55, so consistent with the intermediate risk assessments that I've gotten. And what else can I tell you? Oh, they're recommending that I get a PET scan, just the PSMA PET scan, just to see if there's anything that comes up in the other part of the gland. But Dr. Schultz didn't feel it was absolutely necessary. But if I'm willing and able to do it, he said it would be another piece of information that would help make that determination whether to treat anything other than the tumor.
Right. Well, you went through the whole list without me asking you a single question, so you were obviously paying attention earlier. So.
Well, Bill, just so you know, and I think Rick knows this from our previous conversations in our meeting at PCRI, I was fortunate enough to land with Dr. Schultz's office about 7 years ago. Right. And that's after my urologist told me there was no difference between his MRI and the one at UCLA. It turns out his MRI is 1.5 Tesla. Didn't pick anything up, and of course, UCLA's 3.0 did. But everything was stable for 7 years. PSA being monitored 2-3 times a year, annual MRI, occasionally an ultrasound over at Schultz's office. So it was active surveillance for 7 years, and then just most recently is when it changed. That finally had to decide whether or not I can remain on active surveillance or whether or not it was time to treat, and then of course what the recommendation would be. So that's the update.
Well, I mean, barring the results of a PSMA PET scan, I think you have a ton of good information. You can't get better advice than the gentleman. I mean, you can't get much better advice than the gentleman that you're going to now, and Dr. Epstein's also giving you the advice. So, if you're going to get a PET scan, did you say you already have one scheduled, or they recommended it?
I think Dr. Brisbane, who did the biopsy at UCLA, had written up an order for it, but I never actually followed up on it. It's only been 2 months, but the idea now that Schultz is recommending it, I'll have to go back and revisit that.
Yeah. Personally, I would say it can't hurt. What does everybody else think? I mean, does he need more information?
Yeah, I mean, what are the locations of these 2, 3 plus 4 tumors, or that were thought to be 4 plus 3? Where are they, Mark?
No, it's all just one tumor, Rick. It was just 5 cores that were taken, 3.
Okay.
Yeah.
And what's the location of the tumor?
Hang on, I'll give you the exact, rather than try and make it up. Bear with me. Right posterior peripheral basal midgland.
Basal midgland. So, if it were me, I wouldn't bother getting a PSMA. I mean, I think that what we see happen is that because it's there, you do it, and I feel like if the test is not going to give you any information, why bother? It's expensive. It doesn't serve anybody a decent purpose, and there's absolutely no reason or indication to think to suggest that your disease could be metastatic now, or gotten out the tumor. Now, if it's somebody like Greg Boyd, where it's pushing up against the tumor, yeah, every good reason to do it. But if it's not pushing up against the tumor, what is the percentage? What percentage of the core did Epstein say was 4?
40 and 50 in the 2 that were originally rated as 4 plus 3 by UCLA.
Okay, so it's on the margin,
Right.
It's about half and half. It depends who's looking at it, but there's enough 4 in there. Well, I wouldn't. If it were me, I wouldn't bother with the PSMA. I mean, I think from what I know that the likelihood that this tumor is outside the prostate is absolutely minimal. I mean, kind of like what Schultz said, but he said, but if you want to get it, get it. I don't see the point.
No, I've never been a big fan of doing it, not only because of the expense, but also, they're going to inject you with a radioactive dye, which, wasn't on the whole food plant-based diet list of things to put in your
Right.
body.
Right.
So, I mean, there's got to be some side effect to it somewhere. It's kind of like gadolinium.
Now, I think the bigger issue, we got a couple of hands up and people may have something to say on this. I think the bigger issue is, do we treat you focally, or do we treat the whole gland? I personally am not a fan of focal treatment because way too often we see focal treatment recurring. And if you're going to go through it, the procedure, get the whole gland done. Now, I would ask Schultz, if he sent 500 people for focal treatment to Albert, I'd ask Schultz how many of those people had recurrence and needed follow-up. Because
Well, his comment to me earlier on when we spoke was like that there was almost no incidence of erectile dysfunction or whatever when they did that, and he only had a couple of patients that had recurrence. Of the 200 who had the focal, 300 others treated the whole gland, and I don't think he mentioned how many.
I don't believe him. I don't believe him. I mean, that's my own personal opinion. I don't believe him. The rate of recurrence in all focal treatment across the board is 50%. And a lot of those people that they treat are 3+3s who didn't really need treating anyway. So the ones who are 3+4, the rate of recurrence is a lot higher for those focal people. And anybody who's saying, well, that's what it is, I just don't buy it. I mean, if you ask Albert, I bet even Albert will tell you that and he's not going to overstate it because he gives he gives that treatment, but I bet he's going to tell you 40%, 35, 40%. And the problem is that when you only treat that, you've got a fair amount of four. How big is the lesion? How many centimeters?
1.8.
Okay, so you got a 2 centimeter lesion in there, of which 1 centimeter is 4. So the problem is that 4 gets out into the rest of the prostate and it swims around and the cells are still there. And so if we just treat what we see, we can't treat all the micro little 4s that are running around, which are going to result in your disease coming back. And whilst it sounds great just to do the focal part, we see too many people who have had focal treatment. And in this case, it would be high dose brachy focal. And, it's a problem. Now, back in the day, Albert used to do this with 1 session. He used to do the whole gland with 1 session. And then he stopped and started doing it with 2 sessions. I heard he went back to 1 session, but that's a good discussion that you can have with him too. How about we did the whole gland, but we did it all in 1 session? Would you do that for me? And see what he says. Because some of these guys are doing HDR in 2 sessions. They used to do it overnight. Then they did it a week apart. And then they said, oh, we don't need to do 2 sessions. We can do it all in 1 session. So, there's different styles of doing it. But Albert Chang's a very good doc. Anyway, we got some hands up. Go ahead.
Tom O in New Jersey.
Wrong button. Yep, there we go. So couple things when I was speaking with the MSK doctor. Apparently there's pelvic lymph nodes that are non-biopsyable and possibly metastatic or metastatic. So that almost leads me. So they're on the fence. So that puts me in a quandary whether to do. That puts me in a quandary of surgery or radiation, because if I do
Tom,
surgery,
time out. We'll come back to you.
Okay.
But let's finish up with Mark. Okay.
Oh, I'm sorry. Okay.
Because we're in the midst of talking to Mark, so we'll come back to you and come back to your situation. If you want to bring in other information. Go ahead,
That's
Bill.
fine.
Yeah. John, Dr. John, you had your hand up.
Yeah, kind of similar to Rick's question. Would anybody add 3 months of Orgovyx to this treatment? 50% 4, 50% 3?
So not if it's breaky. Are we talking about, you're talking about if it's breaky, or you're talking about if they did it with SBRT?
Either way.
Okay, so if it's breaky, the answer is no. I've never seen, they don't usually add to breaky. If it's SBRT, back in the day, they always added 3 or 4 months, one shot. But this trial that was reported, this meta trial that was just reported, that I wrote up in the high risk recurrent advanced reminder, now believes that it's just not necessary with a 3+4 to add. There's no benefit to adding hormone therapy. They don't think that there's a benefit to adding it to a 4+3 unless you have another risk factor. They do think that there's a benefit to adding it to somebody who's high risk or very high risk.
Very good. David in Portland, you had your hand up.
Let me just check. Does that answer your question, Dr. John?
Yes.
Okay, and take a look at the meta study that I just wrote up. I forget what it's called.
Okay, go ahead, David.
Let me add to the comment about ADT. I met with Albert Chang myself, and a friend of mine with a 4+4 met with Albert Chang. My friend ended up getting treated by Albert Chang. I did not. For both of us, Albert Chang recommended no ADT, which really threw me. I mean, I thought that was quite surprising that even for a 4+4, he said no ADT for my friend. And that's what he did. He didn't do ADT. But I do know, in terms of brachy and ADT, I know there are definitely doctors, highly respected doctors like Stephen Frank, who do recommend ADT even with brachy, not for a 3+4 necessarily, but Mark here, he's kind of so close to being a 4+3. I'm just kind of like wondering myself whether it would be maybe beneficial to do ADT just to kind of cover that base. I don't know.
Well, I'm just about to post this meta study that was published in JAMA. Was it published in? Yes, it was published in JAMA Oncology. Kishan and Spratt were the authors. Actually, this is actually to the article that I wrote, and the so whoops, that should have gone to everybody. And You know, they seem to think no, but I mean, this discussion has been around prostate cancer as long as I have, if not quite a bit longer. So I don't know.
Yeah.
I
So
asked
really,
I asked my medical oncologist, should I do 6 months or 9 months of ADT? And I was expecting her to give me a medical answer. She said, it depends on your personality. If it will calm you down, do 9 months, but it's not going to do you any more. And if you only did 6, so I ended up
So
doing
David,
just.
if you read what I wrote in my piece, and I'm just going to post here the JAMA link. I say right in there that when I was right in the middle of my 28 months, a study came out 18 versus 36 months. And I wrote to Mac and I said, Mac, what do you think? You think I should do 36 months? Should I go on? He wrote back. I think I've even got it. He said 24, 30, 36. Who knows? And so we don't know. And I agree with your medical oncologist, to be honest.
Well, in fact, there was even, are you familiar with the TRIP trial? It was published last year. It's a Japanese study. It compared 6 months to 36 months in high risk people and found no difference.
yeah. I was going to say earlier, Rick and I have discussed this in different groups, probably,
Yeah.
I don't know, every few months for the last 10 years, Rick.
Yeah.
Because Rick and I both did long-term ADT, and we would have loved to have only done 6 months. But as I said earlier, the treatment was what the treatment was, and I'm doing fine now. Paul, do you have something? Paul came in late.
Yeah, yeah. So just quickly back to just the general question whether ADT is needed. So I had advice from two oncologists, one from Hopkins and one from Inova in Fairfax, Virginia. So basically, the test that they prescribe is one is Decipher, and the other one is Altera AI. So their guidance in there, based on the test results, that determine suggest if I needed ADT in my situation. So Decipher was first, and Altera AI was basically kind of like a confirmation of the Decipher test. Obviously, there's the risk factor for long-term outcome, all that. But one of the components of both tests is, and it's sorry, it stated clearly in the language in there that this situation, this patient, ADT is not recommended or required or suggested. So those are the tools that I've been guided by oncologists to use, and they use those to also make their recommendation to me in my situation.
Interesting. So, Mark, you didn't have a Decipher test?
Yeah, I did. It was 0.55.
Yeah.
So somewhere in there, sorry to interrupt,
Actually,
but it
did.
says
It's in my notes.
yeah, to say something about ADT is required or not, or suggested or recommended or not.
No, as David pointed out, Dr. Chang said he does not think it's necessary, in my case at least. So he was not recommending any ADT. And Rick, if I may go back to asking you, Dr. Chang said, and Dr. Scholes confirmed it, that this procedure does not preclude me from having another treatment if down the road there is something else that recurs. But if I do treat the entire gland, Scholes said the likelihood of having some sort of serious side effect in terms of sexual performance, erectile dysfunction, and so forth dramatically increases. So it almost seems like a bird in the hand, versus two in the bush. If there's no downside to precluding me from having a subsequent treatment if I ever need it, which I may not, why expose myself to the additional radiation and the likelihood of the side effects when I might not need to?
Well, because I would say that there is a very, in my view, and I would disagree with respect to Schultz. I disagree with him. I think there is a very high chance that it will recur. And the problem when it recurs is how and where does it recur? We can't be assured when it recurs that it's going to recur as as confined. We've got guys in the high risk and recurrent advanced group where the disease has come back and it's already gotten out into the lymph nodes, and they didn't know it was happening. So, would I knowingly want to have little Gleason 4 prostate cancer cells swimming around my prostate, the healthy part of my prostate? No. So I think that whilst it's true, it may not preclude you, it's also not fair to say, well, if we treated the whole gland, you're going to have all the side effects. You may not have those side effects if he just treats you focally, assuming where the location of the tumor. But it's too much of a risk for me to know that I got Gleason 4s and I'm not treating them right now.
And to go back to what you said before, you wouldn't necessarily recommend, you would, if you were in my position, you wouldn't sign up for the PSMA to see if it shows anything else in the gland?
No, because the likelihood is now that where you stand right now, that it hasn't gotten away and hasn't gotten out the gland.
But your assumption is it might be microscopically in other parts of the gland, so it might as well treat the whole thing.
And it might do. So when we treat it, we'll nail everything that's in the gland. But do I think it's gotten out now? I don't know. I mean, I'm not a doc anyway, but I mean, from what you're saying, I think most doctors would say what Dr. Schultz said. Highly unlikely, but you can do it if you want to do it.
Right.
Which I mean, I go back to my comment that it can't hurt to have more information.
Meaning that Bill, meaning that you would recommend the PSMA PET scan?
Yeah, I'm saying it wouldn't hurt you to get the PSMA PET scan for more information to help, to help you decide, But the PSMA PET scan is not going to show micrometastasis, right? It's going to show spread. It's going to show metastasis outside of the prostate.
Right, and so we can't recommend.
Nick's point still stands, right?
Mark, we can't recommend. I think what you're hearing is if it was Bill, he might get the PSMA. If it was me, I wouldn't get the PSMA.
No, exactly.
No,
listen, that's why we're here. It's the support group and the opinion. So I'm not taking it as medical advice or a recommendation. I fully understand.
I'm a glorified security guard. I am not a doctor.
On a desert island, no less.
I'm dangerous with a
did you have better than a 2.1 grade point average?
I want to brag, but
oh, I think that Monday Night Football game must have gotten a bit better. Oh no, he's coming back. I thought we'd lost him to the Monday Night Football game.
It was 2.14 to be precise.
So Mark,
which gets rounded down to 2.1 if he was in statistics class.
That's right. That's why. Yeah.
Is it the dean's list there?
10-3 Niners halftime.
Hey, listen, like we said, be careful what you say because Bill's daughter's at USF, right? So we have to be careful. We have to be very respectful of USF. You know that.
All right.
It's come a long way.
Larry in Alaska, are you there?
Yes, I'm here. I just put in the chat, but I'll repeat it here by voice.
Okay.
To me, it's a choice in my mind between hit it hard and fast with risk of side effects, or hit it minimally with a little bit higher risk of recurrence. And so you gather as much information as you can, and you make your choice and live with it.
Yep. No, I understand that. That's why I'm here and checking your guys' history and advice and opinions. So that's just one other thing. Rick, at PCRI, Dr. Cooperberg was very impressive. You think there's any value and benefits in getting another opinion or talking to him?
Frankly, if you were willing to go up north, I probably would talk to Peter Carroll before if you can get an appointment with him before. I'd rather talk with the teacher than the student.
Okay.
So if that's something you want to consider, see if you can get an appointment. And he may see, if you tell him you're an AnCan guy, he may see you. He's cutting back on a lot of stuff, but he's so damn good. And if you make it clear that this is just a second opinion, he may well see you.
Okay.
All right, there you have it.
Thank you.
Sorry, I winked out there. What I missed?
Nothing. You've been here the whole time. What are you talking about? You never left.
My computer went off, and I had to leave and come back.
I'm messing with you. I'm trying to make you think you had cognitive issues.
So we've still.
I had those with Orgovics.
We've still got Martin.
I'd like to get back to Martin. He has told me in the chat that he has his biopsy report. So maybe he can give us a little bit more information. He's been hanging in there the whole time. So
I have been. And well, first of all, the Decipher score is between 0.45 and 0.60. So I'm assuming that's like 0.50. Now the cores, I don't understand, guys, because I'm looking at this. It has a clinical stage of T1C, and then the Gleason is 4.3. And I'm looking through this, and nowhere. I mean, I've got a couple pages where it's all kind of grayed out. I don't see it talks about luminol and stuff like that, but I don't see anything where it has to do with core.
So it doesn't say anything about where the core was taken from, what the percentage was, positive or negative. That none of that's in your biopsy report.
Well, not that I can read.
Hold on just a minute.
Yeah.
I've got some background noise.
I could tell. Yeah, I mean, it talks about sample preparation. It talks about references. And then it goes on to Decipher score, androgen, receptor activity, cell cycle or cell cycle progression.
This is so is this more than one sheet that you've got there, or is this is this your
Decipher?
This is your Decipher report.
Yeah.
Oh, well, we wanted information from your prostate biopsy.
Oh, duh. God. Where do we have that figured out? All right, give me 1 second, guys. I'm so sorry.
All right, Tom, Martin, while you're doing that, we're going to move on to Amir, who has also been hanging in there the whole meeting. So, Amir, you are up.
Thank you. Actually, I want to let my wife explain the updates because she does a much more detailed job than me.
All right.
Yeah, he got his Decipher back and it was 0.76. So as a reminder, his highest Gleason with the original pathology was 4+4. OHSU we, unbeknownst to us, asked for the slides because of a referral that was made to a doctor at OHSU. So their pathologist put that one at a 4+3. We have requested for Dr. Epstein to get the slides, but it sounds like OHSU has been holding on to them for quite a while. So we today just requested a rush, like get these things back to the original pathology lab, and then they'll forward them on to Epstein. Let's see. He has his PSA had a one last week or the week before was at 5.1. So it had been in April, and this is on finasteride, so you have to double it. So previous to that, it was a 5.6 in March, 4.7 in April, and now 5.1. So there's that. And we have talked to lots of doctors. And David in Portland here has been amazingly helpful at sharing lots of information and research. I can't even thank him enough. So we have talked to Dr. Peter Rossi in Colorado about high dose rate brachy. We are registered with MD Anderson to try to talk to Dr. Frank, but at first available is not till the middle of March. And they possibly might recommend a different doctor there, Dr. Hassanzadeh,
Hassanzadeh,
and another Persian guy who works with him. We've talked to some other doctors here who, we felt like we're at a used car sales shop to, just get on with it and have their IMRT and 18 months of ADT. We reached out, well, I actually reached out to Elene Efsantu that's coming to OHSU to head up.
Estafiu.
Thank you. I just messaged her on LinkedIn because I couldn't find anything as to when she was coming, and I don't know why, but she did respond like in about 20 minutes to my message.
Because she's bloody amazing. That's why.
She's a wonderful person. That's why she responded.
Believe me, I sent her a little email yesterday about something. I actually read a really good article about Dr. Drucker, who is heading up this new big cancer center. You've probably heard his name in the news. And I read this article in ASCO Post. And after I read the article, I realized why she was so eager to come up to Portland to work with him. And I sent her a little article. And the next thing I get is a picture of her and her partner standing in front of a football stadium with Dallas Cowboy hats, Dallas Cowboy hats on. But she's special. She's really special.
Yeah, I was surprised. Yeah, so you probably already know, she said around the end of January, and it wouldn't be till she got here and was already working until they would even set up any appointments with her. So we've been trying to get a referral to another doctor there that David suggested, Thomas Beer, for a medical oncology appointment.
Did you say Thomas Beer?
Yeah.
Yeah, he hasn't been seeing patients for the longest time.
Oh, really? It says accepting new patients on their website, but I don't know.
He it looks on the website, it says he's now started accepting them.
Oh,
again.
Really?
Yeah.
Oh, well, if you can get Tom Beer, go for it. But I didn't. That's news to me. Thank you for letting me know. I'll have to talk to E and find out what the story is. But yeah, if you can get it, but you don't really need, with where you are, you don't really need a medical oncologist. You need I mean, maybe to help you decide which way to go, but you don't have a level of disease that warrants input from a medical oncologist. And a lot of medical oncologists won't even see you. I mean, Eleni may be different because she's special, but recently we had a guy in Jersey at MSKCC, and we said, go down to Monmouth Hills and see Chuck Ryan, who I've known forever, he wouldn't even see this guy because the guy didn't have confirmed metastatic disease.
Yeah.
So, you know, one of the things I would say to you is stay focused on where you want to be. And that right now is what's the best type of radiation for you.
Mm-hmm.
And you know, you don't really need to see surgeons. You don't really need to see genitourinary medical oncologists, thank God. If you were trying to figure out, should I do surgery or should I do radiation? Yes, the GU medoncs can be very good, but you don't need them. And a lot of people, they just sort of go see whoever they can see just because they think more information is better. And I don't necessarily agree that more information is better because more information, especially with prostate cancer, can be more confusing. So, but other people would disagree with me and they're entitled to.
Yeah. Interestingly, Dr. Rossi, we only had maybe 40 minutes, I think, with him, but he's, with what he had, which is a very small amount, whichever is the highest, 4+3, or if it's a 4+4, is only 8%.
Yeah.
He's recommending no ADT, just do the high dose rate brachy. So I don't know.
You know, I mean, if you click on that article that I put in just before, this meta study that got published, that Dan Spratt and what's his name from UCLA, Agar, whatever his name is. You know, they're saying, well, with that level of disease, if you have a couple of factors, maybe 6 months, but you heard the discussion before. Some guys will do it. Chang wouldn't give it to you.
Yeah.
And if you did SBRT, they might give you 6 months.
Yeah. Would the Artera AI test help determine whether that would be useful?
Yeah, I mean, in theory, that's what it's for. But then again, you know, you read Artera. Artera says, "Oh yeah, you should do the HT," and then you read this study that was just published, and the study that's just published might give you a different result.
Mm-hmm.
And what they did is they looked at, can't remember. Oh my God. I mean, this is crazy. I just wrote this and it's gone from my mind. So what happens when you get old? There were 13. I mean, they review in this meta study. Do most of you know what a meta study is? It reviews studies that have already done, and it tries to draw conclusions out of all those studies. And let's see, how many studies were there? There were a lot. I can't remember. I'm just trying. I know I put it in there, so I think it's 13 studies that were in there. So, you know, there's been so many 18 versus 36 and 6 versus 36, which David told us about tonight, and 4 versus 28 and 6 versus and so there were 13 trials that they compared, right? So is the Artera going to do a better job in comparing them than Dr. Spratt and Dr. Kishan? I mean, if it was my money, I'd go with Spratt and Kishan. But they may not have the depth of AI that Artera has. But you know, they're very well respected. I don't know. Dave, I'm sure that David has some opinions on this, and he's being very polite and very quiet. But I don't know. I don't know. Who would you go with, Artera or Spratt and Kishan?
Well, I'm going to have to go back to the personality. It's all about personality. For me, I'm a belt and suspenders kind of guy. I would do the ADT. I'd do it for 6 months. If I was Mark, I'd get the PSMA test. I like lots of information right off the bat, lots of baseline measurements, but that's just me.
Well, look, they concluded, they said the meta-analysis suggests 6 months for 2 or more intermediate factors. So that's PSA between 10 and 20, grade group 2 or 3, and T2, B, and C. So if you have 2 of those things, then they would say 6 months. If you have 1 of those things, they would say nothing.
All I know is in my case, the ADT, the side effects were so mild because of exercise that it really wasn't even an issue. Now, I know that's not true for everybody.
No.
And, you know.
And that's really the problem. I mean, 6 months ADT shouldn't bother you. But in all the years I've been doing this, I've seen a couple of guys go off the deep end with 6 months ADT, but it's really rare. It's in the tail. Most people can handle. I tell most people you won't even feel it in over 6 months. But yeah, once you get to 12 months, you do feel it. As Bill will tell you, I will tell you, Dr. John will tell you.
Yeah, for sure.
Yeah.
Great. Thank you so much.
Oh, you're very welcome. Come back and talk to us again.
Yeah, and I also want to say a huge, big thank you to David, because it makes such a difference when you got somebody in your backyard. Have you guys got together and met each other in person yet?
No, my bedtime is so early these days. I'm coming off of a very trying year, so we're basically sticking with online for now.
Well, you guys have to get together and see each other. You do. You have to. It's a requirement in AnCan, right, Mr. Bill?
This is true. I was in Atlanta last week and went to dinner with an AnCan guy who lives there. So.
We love that.
Yep.
We love it. We love it.
All right. So everybody's hanging in. We are at the 2-hour mark, so don't feel like you have to stay.
Yeah. I think Tom wanted to come back to us on something.
You're muted, Tom.
Yeah, sorry. So because I'm still in a quandary over, and I wrote down ADT. I'm going to look that up also and do some research on and ask my MSK doctors about that. But they located 2 potential risk areas outside of the prostate and the pelvic that non-biopsyable because of location and almost inoperable, which has got me leaning at radiation versus surgery. Anybody have any experience with anything outside the prostate that's non-biopsyable, semi-inoperable?
Well, I mean, I have experience with stuff that was outside the prostate, and I was originally staged at T1C, and then back in the day when we didn't have all these fancy scans that you have today, but we had something called a color Doppler, which very occasionally gets used. Dr. Shinohara at UCSF said, I think there's more going on here. And they ultimately restaged me as a T3A. And that they thought that the disease was in the prostate bed. already. Now, once you get to that point, if they think that that's where you are, you don't have to do anything. Our strong recommendation is that you run the MSKCC nomogram, which tells you how likely surgery alone is going to be successful. And that's on the MSKCC. We can give you the link and what have you.
Yeah, they mentioned the nanogram.
So that nomogram is great. And I will tell you that the first time I walked in to see my urologist, my urological oncologist, that was the first thing he gave me. And he said, you know, we could do surgery, but it don't look so good. And it was very, very helpful to me in making a decision, because I would have done surgery and I was young. So what I would say is that if you think the disease may be out, and there are suspicious areas, then yes, you are a very good candidate for a PSMA scan. Have you had that scan yet?
Yes.
And did the scan see any disease outside?
They couldn't. Basically the reading, the way it reads doesn't mean a lot to me. It says intermediate small pelvic lymph nodes positively reactive, possibly reactive, possibly metastatic.
So I think you've got to get somebody to sit down with you and go through that, whatever it means. Because I can't interpret that for you, but if they think that you might have disease out there, then would that influence? Yeah, I would be doing SBRT and IMRT across the pelvic, across your pelvis.
And those alphas don't mean anything to me. I'm new in this. Well, I don't know what that means.
Okay, so SBRT is stereotactic body radiation. It's the intense. It's the intense radiation.
Okay.
And then, and the way Mac Roach does it now is he just does 2 sessions to the gland, and he does 20 to 24 sessions across the pelvic girdle, and he radiates all of those nodes.
Okay. Yeah, because he said that the one course of action would be go through the surgery and then just monitor your PSA. And then if it spikes, obviously the lymph nodes are definitely cancerous. But
but then you're going through 2 sets of comorbidities when you didn't need to. That's what Bill had to do. My big advantage over Bill was that I didn't do the surgery. I went straight to the radiation and hormone therapy.
Yeah.
Because I was willing to do the radiation and I was willing to do the hormone therapy, which at that time was 28 months.
Yeah. Yeah.
And that was no peak, but it worked for me. Now, for you, if we think that there's something out there and you're not sure, I would be doing radiation. I would be doing radiation plus to the gland, plus and the reason I say radiation to the gland rather than the brachytherapy we've been talking about is because, which is what I got, I had seeds, is because that's now where Dr. Roach's thinking has gone, and he thinks you're better off with just 2 shots of SBRT to the gland, which is basically doing this sort of cyberknife type of stuff. SBRT is the same as cyberknife. Cyberknife is a trade name for one type of SBRT. So doing that and then doing several sessions across your pelvic girdle, and that's considered to be the gold standard with the ADT.
Okay. Perfect. Thank you. I don't want to delay the close of this meeting. It was a great meeting as always. Thanks, guys.
You're welcome.
All right. Now, I am going to say one little thing before Mr. Bill closes up, which is that a few of you on here get both of our reminders, but not many of you. Most of you are just getting the low intermediate, but a few of you are getting the high risk, recurrent, advanced, and the low intermediate. And this week, totally independently, or as Mr. Bill likes to call it, serendipitously,
yeah,
we both wrote the same message to you at the beginning.
very, very similar messages.
Very similar messages, because we were on the same wavelength. Okay. And the message was, just make sure you value what we're bringing to you. Because it is, what is it they say? Some things are priceless, but for everything else, there's MasterCard. So, what we bring you is priceless. I mean, just connecting Amir, and I forget your name because I wrote it down, but I can't see what's your name, Mrs. Amir?
Sandra.
Sandra. Just connecting Amir and Sandra to David, that's priceless. And this is what we're doing, and we're doing it 4 nights a week. And we just want you to make sure that you recognize that. Right, Mr. Bill?
That is correct. Yep. It's if you read my reminder tonight, you know why I wrote it. So the other organization is not to be named, but it was not worth going to that virtual prostate cancer support group. So all right. Martin and I communicated offline. So I'll talk to him later. It is 10:11. We've been here for over 2 hours, gentlemen.
Yeah.
So on the East
And
Coast,
Bill,
it's past my bedtime. Yes, Rick.
Dr. John said he would look at that Decipher report.
Okay. Yep. Larry, you have your hand up, or are you waving goodbye?
Yes, I was just going to echo what Rick said. The synergy of a group of people coming together is priceless, and yeah, here we are.
Thank you. All right. With that, I'm going to stop the recording, and this will conclude the November 24th AnCan Low and Intermediate Prostate Cancer meeting.